Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. So let's have a look. This is the homepage. Up here in About, you will find my credentials. And then we have Atlas, 2 atlases, which is work in progress by now. Transthoracic and transesophageal, here are different chapters. In Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, analysis and quantification of the left ventricle, the mitral valve, the Montgomery plaque classification, for example. And then you will find formulas and calculations, guidelines, references, a complete echocardiographic, an example of a complete echocardiographic examination. And online calculators. Here I have created Excel spreadsheets that you can use on the website with calculations for echocardiography, evaluation of diastolic function, and based on the 2016 guidelines, and based on the European guidelines, indications for surgery or transcatheter therapy for the different valves, aortic, mitral, and tricuspid. For example, the calculator here for diastolic function, if you scroll down, is here. Okay, so in this window, which you can use if you fill up the yellow fields, like for example, ejection fraction, the 2D echocardiographic examination, various measurements like mitral valve, tissue Doppler, etc. The Excel spreadsheet will give you, based on the variables that you input as output, the filling pressures, estimated filling pressures, and diastolic function class. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis, and then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusion. Why is it important to consider all of these different filling pressures in diastology? Because with the exception of the early diastolic pressure, the Y pressure, which cannot be estimated echocardiographically, is only measured invasively, all the other pressures, pulmonary diastolic pressure, wedge pressure, mean left atrial pressure, and diastolic pressures, the two end diastolic pressure of the ventricle, can be estimated with our pulse Doppler echocardiographic measures and calculations. And different measurements and calculation, non-invasive measurements, can correlate with these different measurements. This is why we have to differentiate between them. And for example, pulmonary diastolic pressure, wedge pressure, and mean left atrial pressure, diastolic pressure, mean left atrial pressure, wedge pressure, all correlate are closely correlated between them and are different from left ventricular and diastolic pressures here, pre-A and post-A. And this is important because left ventricular, pre-A, and diastolic pressures can be different in the clinical setting from left atrial mean pressure and wedge pressure. For example, in a restrictive cardiomyopathy, you can have an increase in LV and diastolic pressure with still normal mean left atrial pressure. For example, acute mitral regurgitation, you will have an increase in mean left atrial pressure, but still normal left ventricular and diastolic pressure. Now let's look at the array here of different pulse, continuous wave, and 2D parameters that we can use with non-invasive echocardiography to estimate these invasive pressures. So here, from right to left, here we have tricuspid regurgitation. Why tricuspid regurgitation? Because tricuspid regurgitation correlates quite closely with wedge pressure. Then we have the collapsibility of the inferior vena cava, which we use in our calculation because this correlates closely with right atrial pressure. The end diastolic velocity, pulmonary regurgitation. So pulmonary regurgitation is here. The end diastolic velocity pulmonary regurgitation will give us pulmonary artery diastolic pressure, and as I said, this correlates quite closely with wedge pressure. And so also mean left atrial pressure, because wedge pressure, mean left atrial pressure, if pulmonary vascular resistances are normal or only mildly elevated, correlate closely. Then we have in all the diastology, the combination of pulse Doppler mitral flow profile and pulse Doppler right upper pulmonary vein profile. The combination of them gives us parameters which correlate with mean left atrial pressure and wedge pressure. Then we have the E on E prime ratio, so E, the peak E wave velocity of mitral flow, and E prime peak peak E prime wave of tissue Doppler, and this ratio correlates with both pulmonary wedge pressure and left ventricular and diastolic pressures, depending on the differently published data. And this is a problem because this added a lot of confusion, because as we have said, these pressures can differ in different clinical situations. So it is still unclear if E on E prime correlates more with wedge pressure or left ventricular and diastolic pressures. And then we have the peak velocity of mitral regurgitation, which when combined with sphygmomanometric arterial brachial pressure can give us a direct measure of mean left atrial pressure. Well, and is it necessary to study cardiac physiopathology before dedicating ourselves to the evaluation of diastolic function? Yes, it is. So you see here a very recent echocardiographic examination in a hypertensive 74-year-old lady with mostly asymptomatic. So this is pulse Doppler analysis of mitral outflow. Here, this is Italian, in fact, it's an Italian examination. And the cardiologist measured the slightly hypertrophic left ventricle with a normal left atrium, normal systolic function, normal pulmonary systolic pressure. Look at the mitral outflow. The peak E wave is 85, measured as 85, and the A wave is 111. But the placement of the crosshairs is not correct, as you can see. The values are much lower, and in fact the E and A wave are basically equivalent, and deceleration time is 190. So this EA transmitral flow pattern is basically normal, even for the age of the patient. But look at the diagnosis of the cardiologist here. It's abnormal ventricular compliance diastolic function pattern, which is completely wrong. As we have said, this pattern here is completely normal. And the cardiologist here only did a mitral flow measurement, not any other of the many measurements he could have made for diastology. So diastolic function here is normal. By writing in the report abnormal ventricular compliance, the cardiologist is implying, but I think he is completely unaware of this, that this is a restrictive filling pattern with increased filling pressures, severe diastolic dysfunction, and bad prognosis. In fact, what I suspect here is that the cardiologist is confusing in his mind compliance with relaxation. This is very bad for his patient. This is one of the reasons why we have guidelines in diastology. Well, we don't have actually guidelines, we have recommendations because there are no randomized trials. These are the latest, which you should download if you don't have them already, using these two QR codes here, which point to the PDFs on internet. The 2016 extensive joint from the American Society of Echo, and on this side of the Atlantic, the European Association of Cardiovascular Imaging, and the latest as an update to the 2016, the 2025 recommendations, which are, I don't know why, but they're not shared by the European Association of Cardiovascular Imaging. You should read them both. Most of the information is the 2016, the 2025 recommendation being mostly an update, but with a difference in the algorithm, so you should read them both. Okay, so to make a long story short, these are the 2016 algorithm. There are two algorithms to diagnose diastolic dysfunction and increased left ventricular filling pressures. The stated goal by the team was to simplify analysis of diastolic compared to previous recommendations. You may ask yourself, how were the previous recommendations? Well, you'll have to have a look in the literature. There are two algorithms, as I said, one on the left and here and one on the right. The first on the left is with patients which have a baseline normal ejection fraction and 2D echocardiogram, so no hypertrophy, no left atrial dilatation, for example. And the second algorithm for patients with reduced ejection fraction or patient with normal ejection fraction but abnormal 2D. So for example, hypertrophy of the left ventricle or left ventricular dilatation. The required parameters, the measurements, are peak E mitral E wave velocity, which is part of the algorithm, peak E prime velocity, so to calculate the average E on E prime. The cutoffs are 10 centimeters per second for the E prime on the septal side and 10 centimeters per second for E prime on the lateral side when they're taken as a single measurement. Then we have tricuspid regurgitation, so the peak tricuspid regurgitation velocity with a cutoff of 2.8 meters per second. And we have left atrial volume index. The cutoff is 34 milliliters per square meter, and this is biplane volume. So basically 4 parameters: E on E prime, the E prime by itself, tricuspid regurgitation velocity, left atrial volume index. So not very much and not many, and basically these you all measure them during a standard examination. This is the flow chart. The main problem here is that you have a certain amount of indeterminate patients which have indeterminate diastolic function, so not normal and not abnormal. All other parameters like pulmonary venous flow, for example, are considered secondary. You can use them, but as a second line measurements when situation is not clear or these parameters here are not available. You don't have tricuspid regurgitation, for example, or there's a problem with mitral valve flow. So it's a limited number of measurements, as I said, which are routinely performed. Depending on how many of these indices are abnormal, we define normal, increased, or undetermined, as I said, diastolic function. The main problem here, as I said, is the indeterminate category, which may sum up to 20% of the examinations. So the problem, and here on the right side, you have patients with, as I said, reduced ejection fraction. The algorithm is different because you start with mitral inflow and the E on A ratio. And then you can see you go through measurements which are similar than on the other side with patients with normal EF. And also here you have indeterminate left atrial pressure and diastolic dysfunction grade determination. In addition to this indeterminate patients here and here, you cannot examine with these algorithms all situations where you cannot use transmitral pressure. Well, the transmitral pressure gradient is not normal, for example, like mitral stenosis, or the patient has had mitral valve repair, or if you have significant mitral annular calcification which may cause even mild stenosis, will alter your E on A ratio, which is not valid anymore, and of course mitral valve prosthesis, but also patients with tachyarrhythmias, atrial fibrillation, or many ventricular premature beats. All these may make measurements substantially unusable. So this is a small revision I have made by joining the two algorithms to improve usability. And I have used this algorithm to build a spreadsheet, an Excel spreadsheet, to better understand how the algorithm works. The Excel spreadsheet is here in my website, echobyweb.com, and this is the QR code that you can use with your cell phone to land there. And this is what you will find. You have this spreadsheet. The yellow boxes here is where you introduce your variables. The gray ones are the calculations. And then you have two outputs here. Once you complete the input, this is the legend. You have the algorithm gives you the filling pressures and the diastolic function class. And as an alternative output, you have also the pulmonary diastolic pressures and the filling pressures if you use the end diastolic velocity of pulmonary pressures, as I told you previously. So in the spreadsheet you have ejection fraction, 2D echocardiographic examination, and in this case you insert 1 if it's normal or 2 if it's abnormal, the E and A wave of mitral valve flow, and it calculates of course the EA ratio, septal and lateral tissue Doppler E prime, and it will calculate the mean value, and then you will calculate the E on E prime mean ratio, which goes in the algorithm. You have peak velocity of tricuspid regurgitation, the indexed biplane left atrial volume, and the end-diastolic velocity of pulmonary regurgitation, and estimated right atrial pressure. And here you have the estimation of pulmonary diastolic pressure, okay, which you obtain from end-diastolic velocity, Bernoulli equation simplified, and then you have a gradient between the pulmonary artery and the right ventricle, and you add this to estimated right atrial pressure, and this gives you pulmonary diastolic pressure, which correlates closely with filling pressure. So let's see what happens here if we play a little bit with the algorithm. So let's say we have a patient which has a normal ejection fraction of 60. The 2D examination is normal, so we put 1. A peak E wave of, let's say, 75, and A wave of 60. Then we have E septal, which is 9, lateral, which is 11. So you can guess that I'm inputting normal values. A peak velocity mitral valve of 2.1. LA volume index of, for example, 32. And you can see here on the right that we have normal filling pressures and a normal diastolic function class, which means 0. Then we may have a patient which still has a normal ejection fraction and abnormal 2D exam, and at this point the algorithms give me immediately diastolic dysfunction class 1, so this patient cannot be normal, with at this point normal filling pressures. Then we will have like 45 centimeters per second here and 60 here, so E on A ratio of 0.8, which makes sense with diastolic lung dysfunction. Then we have, let's say, 70 septal here, 8 here, which is so prolonged relaxation, measured prolonged relaxation, and the algorithm still points there to class 1. Then we have, let's say, normal tricuspid regurgitation and a dilated atrium. Okay, so this is typical diastolic dysfunction class 1 with normal filling pressures. Then if we have the same patient increases, let's say, tricuspid regurgitation to 3.4, it still remains a class 1 diastolic dysfunction with normal filling pressures here and here. Don't look down here at this one because this is another algorithm. We'll go there in a few minutes. And let's say now that you have a patient with a reduced ejection fraction, which is like 38, abnormal exam, and then you have 80 E wave and 45 of an A wave, and then you have reduced, moderately reduced prolonged relaxation because of reduced E prime, and then you have a TR velocity which is increased, and then you have a dilated left atrium. And here we have filling pressures which are increased, diastolic function 2. If my peak E wave goes up to 100, EA ratio is more than 2, and so diastolic dysfunction class becomes 3. Okay, so this is basically how it works. The interesting thing is that you can change and tweak your parameters so to understand exactly how the algorithm works. And this is the algorithm of the new 2025 ASE recommendations that we have mentioned before. The purpose of this algorithm, again, is to simplify the analysis of the previous algorithm, but mostly to reduce the category of indeterminate diastolic function and indeterminable left atrial filling pressures that we had with the previous algorithm. Now, compared to the 2016 recommendations, here there is a unique algorithm, only one, not two. So this is independent of ejection fraction. Although the structure is similar, we have an input, but there is a difference, a large difference, because there is much more weight on the E on E prime ratio. We have E prime velocity, septal cutoff is 6, lateral is 7, the average cutoff is 6.5. So there is a lowering of the cutoff. And the E on E prime cutoff depends if it's based on septal, lateral, or average. The average, which I personally always recommend, is 14. And then we have TR velocity, tricuspid regurgitation velocity, and with the same cutoff of 2.8. As you see at the introduction, at the first step, you don't have left atrial volume anymore. And then going through the algorithm, the other change is that left atrial strain, reservoir strain, is now first line based on the literature of this last 4 to 5 years, and left atrial volume is back as, let's say, as a second line. And another change is that they have taken pulmonary vein ratio, systolic to diastolic wave, and IVRT, which nobody measures as far as I know, the duration of ERT, from second and third line to first line. And so you start by measuring E prime and E on E prime and tricuspid regurgitative velocity, and if you have everything normal, then you go to normal left atrial pressure and normal diastolic function. But if EA ratio is below 0.8, then you go to grade 1 diastolic dysfunction. And then here on the right, if you have more abnormal parameters, you go to increased left atrial pressure. And then the difference between grade 2 and grade 3, as in the previous algorithm we have just seen before in the previous slide, depending on the EA, below or above 2, you have grade 2 or grade 3 diastolic dysfunction. This is the end of video number 2. Please proceed now to video number 3, which deals from measuring pulmonary diastolic pressure with echocardiography to the evaluation of left ventricular compliance.